So I'm going to start back up again. So I said we had 5 different cases, and now we'll step into the first one, which is a patient with hypertension. I'm going to share this person with you and see what you think. And then I have some other slides to back up some content, but I want you to imagine, and these are patients that came through our clinical pharmacy team. So they're referrals sometimes for patients that we were actually asked to consult on and to intervene and to manage. And we manage in our practice patient care through collaborative protocols, which gives us authority for a list of diseases to actually initiate therapy or modify therapies. That's where the source of these patients come from. So the first one is Rhonda. Rhonda is a 64-year-old white woman. She was diagnosed with hypertension 4 years ago. She was treated in the past with hydrochlorothiazide and triamterene, that fixed dose combination product, ever since then. Her blood pressure was pretty well controlled in the past, but it's been slowly worsening. She's seen today for follow-up, and the clinical pharmacy team was involved to assume her care under our collaborative protocol. So what's happened with this woman? She has hypertension, type 2 diabetes, and dyslipidemia. She does not smoke, does not use any recreational drugs. Important to ask because I live in Colorado. She strictly follows a DASH eating plan, so she can actually recite. She uses the website for the DASH eating plan. She prints it out. She follows it better than most patients would. She also exercises 4 times a week. She uses an elliptical machine for what she says and reports to be about 40 to 60 minutes per session. So doing quite well, for at least in that regard. That's probably pretty ideal and more than most patients would do. She does report drinking wine, but only about 3 to 4 glasses per week, which is considered moderate. What else do we know about the 64-year-old patient? Her father did die prematurely of a heart attack at age 50, and she has 2 siblings that have ASCVD. Her medications, she was started on hydrochlorothiazide with triamterene. It's 25/37.5 if you're interested in the triamterene component. But really that 25 milligrams of hydrochlorothiazide is the drug that's lowering her blood pressure, or at least treating her blood pressure. She's on calcium, metformin, liraglutide, and atorvastatin. So she's on a moderate list of medicines. Unfortunately, despite reported adherence with both her lifestyle modifications and her medicines, her blood pressure is 148/90. Her average home blood pressure measurements, 146/88. Her heart rate 676 beats a minute. And she's not obese. She's considered a bit overweight with a BMI of 27.2. Looking at her labs, we have a comprehensive metabolic panel, a lipid panel, her thyroid panel, and her hemoglobin A1C. So from her comprehensive metabolic panel, the things that are jumping out as being abnormal are 2. They're in red. One is her creatinine is slightly elevated. Her creatinine is about 1.15 or 1.18. That correlates to a GFR, if you look to the bottom, of about 50. So her GFR is 50, and indicating some degree of kidney decline. Also, her uric acid, despite no history of gout at all, but she has a uric acid level that is slightly high. It's in the 6s, not gout in her past history, but that has popped up. Her lipid panel, she's on atorvastatin, and her LDL is 65 with diabetes. And, her triglycerides are 150, which are not bad today. Total cholesterol is 140. So her lipid panel looks actually pretty good on that atorvastatin 20. Her thyroid function is normal. And her A1C, even though it's in red, is 6.7. So what do you think of this woman? What concerns do you have as a clinician? 64, hypertension, diabetes, blood pressure about high 140s over about 90. We got that kidney function there. What are some ideas that you guys might have or thoughts? Would you treat this person more aggressively? Why? You would add an ACE or an ARB? Okay. Any reason why? Diabetes and CKD, right? That CKD is really pushing me. I don't have it, whether she has albuminuria, but that GFR is declined, and along with diabetes is not a great thing. What about our current therapy? She's on hydrochlorothiazide with triamterene. Good, bad, or indifferent? What do you think? You take her off the triamterene. Why would you do that? Thank you for mentioning that. So she's on a thiazide, hydrochlorothiazide, very common drug, right? And it comes with that Maxide product or the diazide product, which has triamterene in there. The only purpose of triamterene is to raise potassium or to prevent some of the depletion. Her potassium right now is 5.0, and the range of this lab is 3.5 to 5.0. So it is raising your potassium. Very good, good. I'm glad you brought that up because I don't use a lot of triamterene. Unless somebody has hypokalemia and I have to use a thiazide, that's one thing, but you don't always have to push up the potassium if somebody doesn't need it. And if you add an ACE inhibitor or an ARB, that will raise your potassium. That may make that into a danger zone. So good things. I think another drug, one that treats her underlying comorbidities, but one that won't hurt her, first do no harm, right? From a potassium standpoint, may require just flipping it out. And heck, if you want an ACE inhibitor or an ARB with hydrochlorothiazide, you have a pick of many options, right? That come in one pill. Yeah, there's Zestoretic, yeah. Every ARB comes with hydrochlorothiazide, except for there's one called azilsartan, and it doesn't come with hydrochlorothiazide, it comes with chlorthalidone, but that's a brand name one that we don't use often. So really it would be very easy to do. Now this woman, it's not surprising that somebody would be well controlled and sort of regress. That happens, even with adherence with treatment. Sometimes disease progresses, right? And that is not necessarily because of a lack of what somebody's doing. It could be sort of normal course of illness, or it could be a marker somebody's not adherent. But I want to highlight these data that were published not too long ago. Actually, during the pandemic, I saw this. It was an assessment of the NHANES survey. NHANES, if you're not familiar with it, is a national organization which looks epidemiologically at the United States. And it looks at trends in health. And these are the trends in health. They looked at basically the proportion of patients who had controlled blood pressure. And it actually, so going up is good, right? Because we want people to be controlled. We were doing really good at one point, but after about 2014, it started to dip. And that really is when the JNCA came out and raised the blood pressure goal. Now, what's funny about this is blood pressure control rates, but they use less than 140/90 as the definition of control. If you applied 130/80, it'd be even lower than this. What helps improve blood pressure control is being on medicines, which is the red line, or the red line being adults with hypertension who take antihypertensives. The blue line is our total population of hypertensives. So there's still a lot of people that are just not on treatment. That's why they're not doing good with blood pressure control, right? And lifestyle alone doesn't usually do it. Some people maybe if they're early on, but a lot of people it won't cut the mustard. And this woman, so I like using an ACE inhibitor ARB. You can look at this woman and say, hey, first line therapy is either thiazide, ACE inhibitor, ARB, or a calcium channel blocker. So you can use any of those. But you really should look for the presence of compelling indications. And this woman really has two. She has diabetes and chronic kidney disease. Now, if you look at diabetes, at one point in time, it was sort of an automatic. If you have hypertension and diabetes, always use an ACE inhibitor or an ARB. And there still is nothing wrong with doing that. The benefits that were purported was a decreased risk of developing kidney disease. More data has shown that probably for a pure diabetes patient with good kidney disease, it seems as though a thiazide, ACE inhibitor, calcium channel blocker, ARB are pretty comparable to one another. That's diabetes without any kidney insult. So if you had maybe an African-American patient or a Black patient and they have diabetes, no preserved kidney function, no albuminuria, you could use a calcium channel blocker or a thiazide, probably equally good long-term. But this woman has chronic kidney disease. I would say that based on 2 GFRs that are both 50, separated by more than 3 months, she's got that. It's actually stage 3 or G3 kidney disease. No surprise with uncontrolled hypertension and diabetes. That's what happens to people. And we know ACE inhibitors or ARBs very specifically have been proven to decrease progression of kidney disease. So a very good disease or drug to have considering her disease. I would team it up with 2 drugs. She's going to a thiazide with her ACE inhibitor or an ARB. Heck, you know what? Some people may say this because her uric acid's creeped up a little bit. She doesn't have gout, but if somebody were to say, I want to use an ACE inhibitor with amlodipine, that'd be fine too. Just to avoid what we sometimes forget about is the thiazides can sometimes raise your uric acid. In somebody without gout, I'm not really highly concerned. I might keep my eye on it. But if somebody has a history of gout, I try to avoid, if possible, using thiazides because they do directly raise your uric acid. And some people can trigger gouts. That's their compelling indications there. Another thing I think that I want to just share with you is what the Diabetes Association says about treating hypertension. This has not changed much at all. They do endorse for patients who have diabetes, who they consider higher risk, and their definition is 15%. Don't ask me exactly why they chose 15 versus 10%. It's based on some of the data that they have specifically in the diabetes populations. I might not have just been that literal, but they were pretty literal. That's the point at which they recommend a target blood pressure less than 130/80. So even other organizations endorse this number. They talk about ACE inhibitors and ARBs. And the one thing that they highlight that I think is very prudent is if you have somebody with diabetes and hypertension, and they have not just kidney disease, but albuminuria, that's probably a good example of it's not good enough to just be on an ACE inhibitor or an ARB. They recommend using the highest tolerated dose to minimize progression of specifically albuminuria. So you may notice, hey, that's a reason maybe to use the highest dose, where absent albuminuria, you don't always have to push the dose to the highest range. This might just create extra benefit for kidney blood flow to minimize that albuminuria, something that I think is important to bring up. This woman is doing home blood pressure monitoring. Good thing? Bad thing? Has anybody had success stories where people get more engaged when they use their blood pressure monitoring at home? Or, okay, if you're nodding in the heads. I think it's a real thing. We've had good success. They need proper training. And it's not hard to train somebody to use their blood pressure cuff appropriately. It's the same rules that we should be doing in the office. 5-minute period of rest, put the cuff on bare skin, be seated in that position. Don't stand or go up and down. Don't do it right after smoking a cigarette. Matter of fact, don't smoke at all. Or maybe wait 30 minutes after you've had your morning cup of coffee if you drink something with caffeine. But the American Heart Association, they have just a brief policy statement. And I don't want to go into every aspect of this, but the cardiology groups are pushing for broader use of home blood pressure monitoring. During a pandemic, it's even better tool, right? Because then people maybe don't have to go into the office. There is sort of a problem though with being reimbursed because I'm a strong believer that as a clinician, yeah, we should have patients use tools that inform our decisions and be able to titrate them. We need to work out the payment models a little bit better because if we should be reimbursed for that activity, even if the patient's not physically making it to the office for their follow-up. And I think things like this, the American Heart Association pushing that self-monitoring of blood pressure is indicated, especially for people with uncontrolled hypertension, that there's evidence that it works and that it's cost-effective, will help our pleas. Even if it's coupled with video visits, it's better than actually not doing it at all. I did mention too, when I said you can just add an ACE inhibitor or an ARB to this patient's regimen and maybe get rid of the triamcinolone, you can create an ACE inhibitor with thiazide combination in this person, and it would effectively treat the blood pressure. But you can also switch to an ACE inhibitor with a calcium channel blocker and maybe minimize some of that uric acid increase. There's actually one study that doesn't get talked about a lot, and it's a big study that actually evaluated those two treatment approaches, an ACE inhibitor with a thiazide versus an ACE inhibitor with amlodipine. And it's called the ACCOMPLISH trial. And what they looked at in this study was if there's a difference in cardiovascular events with those two treatment approaches. So a very interesting study to me. It's over 12 years old now. It's called the ACCOMPLISH trial. It's randomized prospective double-blind trial. Half the group went on benazepril with hydrochlorothiazide. The other half went on benazepril with amlodipine, which is a generic combination capsule product of both drugs. For the amlodipine, it's a capsule. For benazepril with hydrochlorothiazide, it's a tablet. Both generic and affordable products. Over 11,000 patients went in this trial. They were all at least age 60 or in the 50s with risk factors. They had systolic blood pressures at baseline, which were 160 or greater. So they really needed two drugs. So these were definitely stage 2 hypertensive patients. They looked at cardiovascular events, and on the right, there was a difference. Those treated with the ACE inhibitor and amlodipine are in red, and they had fewer cardiovascular events. It was about 9.6% versus 11.8% with benazepril with hydrochlorothiazide. I do want to say that either of these combinations are considered acceptable, but there's some data that push towards the amlodipine ahead of the hydrochlorothiazide as being better at reducing events. when they looked at blood pressure differences, the average blood pressure was, the systolic blood pressure was 133 versus 132. So it was lower with amlodipine, about 1 millimeter of mercury. Probably wouldn't explain that difference there. Some people say too, hey, you know, hydrochlorothiazide is not the best thiazide. We should use chlorothalonone because it's a bit stronger. And maybe that's legit. If they would have used chlorothalonone instead of hydrochlorothiazide, maybe those bars would have been equal. But these are real data that are out there in the literature. It's from blinded trials. There are some things to think about. And this is more for completeness sake. I do want to make sure that I'm a big advocate of using antihypertensive drugs, but also for looking for side effects. So when you add more drugs, you have side effects. We know we have ACE inhibitors and ARBs. The ACE inhibitors can cause a dry cough where the ARBs don't, but there is the increase in potassium that somebody mentioned happens with both ACE inhibitors and ARBs because they block aldosterone. There's calcium channel blockers, which overall are metabolically neutral, meaning they don't change uric acid or sodium or potassium, but you can have an increased risk of mostly edema. A lot of people that I've treated with amlodipine get lower extremity edema. It's a common thing that happens. It's dose related. There's some drug interactions when you're thinking of rapamycin and diltiazem. The thiazide we talked about, and this is where we see electrolyte abnormalities. Sometimes these are not problematic, but sometimes they are. And so that you have to monitor them to make sure that's not a problem. Beta blockers are not first-line drugs for most people unless there's heart disease, established heart disease. But the biggest things to look at, as we know, for those of us who are prescribed beta blockers, are exercise intolerance, bradycardia, because of the beta blocking effects. Yes?
The angioedema with the ACE, is there any familial risk if you have a family member that's severe?
So the question is, the ACE inhibitor induced angioedema. Is there any increased risk if somebody has a family history of familial angioedema? I don't know the answer to that. I would probably say if it's genetic angioedema, there probably is some risk of just getting angioedema even without an ACE inhibitor. But any patient who has something that's, so I don't have a clear answer for that because I haven't seen it, but I will say if you have a patient who has angioedema from anything in their history, they should never use an ACE inhibitor. It is contraindicated. So if you look at the contraindications, a prior history, individual history, not family history, but a prior individual history of angioedema would preclude using an ACE inhibitor in the future. You can use an ARB. Some people still are not comfortable with that. I have put people with ACE inhibitor induced angioedema on ARBs and not had a problem. And there are data from a study called Transcend that looked at people with a history, an individual history of ACE inhibitor induced angioedema and randomized them to either placebo or an ARB. And there was one case of angioedema in the placebo group, not the ARB group. So when I see blinded prospective data, it does influence me. That's why a lot of cardiovascular guidelines will say, if you can't use an ACE inhibitor because of angioedema, you can use an ARB. And I'm one of those people that's comfortable doing that. Good question. CKD, actually, this is sort of interesting. So what's evolving is there's data looking at CKD patients. Meta-analyses have looked at this, and there's one that's been cited recently, over 18,000 patients, that showed that more intense blood pressure lowering in kidney disease is better than just standard blood pressure lowering. So same old story. But when you look at that data, it was analyzed by the KDIGO group, which is the Kidney American, the National Kidney Foundation. They endorse this KDIGO group, which are the kidney guidelines. So in 2021, they actually embrace this data, and they actually recommend that when kidney disease, that patients be treated to a blood pressure goal of less than 120. And that's, so I bring that up because you may hear about it. I'm not sure exactly whether I want to recommend that globally. I do believe in the proof. If you are treating to a systolic goal less than 120, please do make sure that patients are getting an accurate blood pressure measurement, because if they're not, you don't want to push them too low. So it really calls that you really do need to get an accurate measurement and really probably use those home blood pressure measurements. But the idea there is if you have lower blood pressure, the proof says in kidney disease, it does decrease progression even better than just less than 130. So you may see this if you send, is anybody here a nephrologist? If you send your patient to the nephrologist for a consult and they come back and they want to be more aggressive, it's because this just came out last year during the pandemic, so they didn't get a whole bunch of it, as much attention as maybe it would have non-pandemic, but you may see this as a trend and it may turn into a standard of care in the future. So for Rhonda, what are our options? We're just laying them out there, replacing hydrochlorothiazide triamcinolone with a 2-drug regimen. And I think any of these combinations I'd be okay with. So thank you for recommending those. I would prefer a fixed dose combo product too. Now, I don't always like fixed dose combo products if they're more expensive, but in hypertension, they're all generics, right? You can get them very affordably. Even the ARBs. I mean, we've gotten to the point, there's also some published information. The ARBs really are very equal to ACE inhibitors as far as long-term benefit. But where they are better is side effects and tolerability. They do have better tolerability long-term. It is fine to still use ACE inhibitors, and we still do a lot in our practice, but it is equally acceptable to go first line with an ARB. The biggest frustration I mentioned before is a lot of our losartan treated patients, the availability of losartan goes up and down because of the contaminants that are in some of the manufacturer products. Seems like we have less of an issue with olmesartan. Every once in a while we get it with valsartan and irbesartan, but olmesartan generic too seems to, at least in our local area, we don't have the shortage issue. So finalizing a plan, at least based on what we did in our practice, we deemed that she was uncontrolled. She was not at her blood pressure goal, less than 130/80. We committed to that, especially because of her kidney disease. Maybe in the year 2022, some people may want to say less than 120 for that systolic range. Her current antihypertensive therapy, thiazide is evidence-based in her diabetes. I don't want to, if we switch away from it, it's not because it's bad for her disease. It still is proven. Her triamcinolone, though, it can be elevating her serum potassium, so it may make our future treatment more complicated. But what's not being treated sufficiently is her CKD. And I think we made that point pretty clear. What a good plan for this patient would be to educate her about her goals, just to make sure that she's confirmed that 148 is not in her best interest, and that there's proof that if we get her tighter controlled, that her kidney disease and future cardiovascular risk are both improved in that regard. Educate her about the change. Personally, I would go the amlodipine benazepril route just to avoid any uric acid increases. I would reaffirm her home blood pressure monitoring and reassess. I'd look at her average in 4 weeks after a month on a new regimen. I'd get an average of her values. I probably would throw out the first week, and I would focus mostly on weeks 2, 3, and 4. The first week of adjusting to a new drug, I may just expect that it's on a downward trend from that period. But Rhonda, I mixed Rhonda with another patient that came in our practice. Yeah, we did all that in Rhonda. Mixed with another patient, and she presents 6 years later. So a lot of good has happened with Rhonda. Remember, she has diabetes and hypertension and on multiple drugs, but 6 years later, she returns to your care. She still has hypertension, diabetes, and dyslipidemia. But a year ago, she had a stroke, ischemic stroke. And she clearly now has a diagnosis of G32A CKD. So she's got some albuminuria along with her stage 3 CKD. So she's still on the amlodipine and benazepril, and they've been titrated up to the maximum doses. She's on chlorthalidone now. So she's on a thiazide, but it's the chlorthalidone product, which may be a little stronger. Still on calcium. She's still on metformin and liraglutide, but she's also on insulin at this point. And atorvastatin has been bumped up. She was on 20 before, but now she's on atorva 80 and ezetimibe 10. Her adherence was confirmed through her refill records, so at least we have some markers. She's taking her meds. Her blood pressure, she's still not completely controlled, 138/80, but better than the 148, right? So it's down there. This is 6 years later. She's a different patient now, a little bit more. Your lens of looking at her should be different. Her heart rate's 80 beats per minute. Her BMI is 28, so not obese, but overweight. Her GFR, it's still stage 3, but it's gone over 6 years from being 50 down to 35, so a little bit of a decline there. And she also had a stroke too, so her disease has progressed. She's now 70 years old. Her A1C, that's one thing that's good. It's pretty controlled. And look at that LDL. 48 on atorvastatin 80 and ezetimibe. She has well, actually, what do you think about this patient? What concerns do you have? Are you still concerned about her hypertension? I still wouldn't, but and I'm even more concerned. She still has hypertension. She still has diabetes, but now she's a secondary prevention patient. Her lipids are looking great. High intensity statin and ezetimibe, with an LDL of less than 70, I'm feeling pretty good with that, but she's on 3 antihypertensive drugs. Are those, and we go back to the list, are those good drugs? So let's see, we got an ACE inhibitor, which is amlodipine, benazepril, which is amlodipine is a calcium channel blocker, benazepril is the ACE inhibitor, and a thiazide chlorothalidone. She's on 3 medicines, yet still not at goal. And we did confirm her adherence to her refill record. She actually is somebody who has resistant hypertension. Has anybody here seen a patient with, quote, resistant hypertension? Yeah. I mean, there's a formal definition, and it's not being at goal despite 3 first-line drugs, including a long-acting calcium channel blocker, which is amlodipine, and full dose of 2 other primary drugs, optimally including a diuretic. What we notice with blood pressure drugs is sometimes people have fluid accumulation as a side effect to their drugs, so being on diuretic does help mitigate that to some extent. She meets the definition. This is the definition by the American Heart Association. It could be somebody who's on 4 or more drugs too. Even if they're controlled, they would be labeled as resistant hypertension. Doesn't mean they can't be controlled, just means that that's the underlying pathophysiology. Maybe they have too much aldosterone circulating, or they have sleep apnea, or they have some other secondary cause to their resistant or refractory or difficult to manage hypertension. One thing that's important though is when you have somebody that looks like this, on 3 drugs and not at goal and taking them, you have to ask yourself, is there something else going on? Is there another secondary cause? And some of the data from the American Heart Association plotted to the right is causes of pseudo-resistant hypertension. What is pseudo-resistant hypertension? Well, it's people that meet the definition, but there's something else. There's something else that's driving their blood pressure up. And it could be an inaccurate measurement, no surprise. 1/3 of the cases are because blood pressure was measured wrong. I completely believe that. White coat effect, about 1/3 of patients too. I mean, a way maybe to manage that is to get some home readings to see whether they're normal at home and just get nervous in the office and blood pressure goes up. Way on the right is medication non-adherence. People just not taking even though they're prescribed the right regimen. That's not applicable to Rhonda. But look at the red one, is under treatment. And under treatment sometimes is, even though it's supposed to be the maximum doses, sometimes that's the biggest thing. People can be on 3 drugs, but they're very low doses, which I mentioned earlier, may be a trend that we go to lower doses in combination. But if people don't respond, you should dial up the doses before you start going to the 4th drug. And these are comforting drugs, at least, because otherwise, what are you going to go to? A beta blocker, I'm okay with that. But then we're looking at drugs like spironolactone, clonidine, hydralazine, and those are, I try to avoid them if possible. We use them if needed, but I try to avoid them because they're less tolerated. Some other common secondary causes, just make sure that you rule out some medicines like NSAID use can raise your blood pressure, or oral contraceptives in younger women. Steroids can, like glucocorticoids. There's alcohol abuse can actually raise your blood pressure, or illicit drugs. There's some cancer medicines that can raise your blood pressure, and then some diseases. And probably some of the bigger ones, even though I am a pharmacist, I am not a physician, I'm not a diagnostician or a prescriber. Things like sleep apnea can actually be a cause for refractory elevated blood pressure. There's primary aldosteronism, some kidney diseases on here. Cushing's syndrome, less commonly encountered, but sort of on the list. There's that, the zebra of a pheochromocytoma. You guys heard of that? Has anybody seen a patient with a pheo? Yeah. Oh, yeah. Okay. It's not that common. Have you seen them a couple times in your career, or 2 times? Yeah. Yeah. I mean, every once in a while you'll see it, but it's not as. In medical school, I used to do inpatient medical rounds, and it'd be something that always the med students say, always bring that up as a secondary cause. And it's good. It's just not as common as maybe some other things. These American, so what do we do? So I went over sort of the ACC AHA guidelines of a broad blush. This woman's already on 3 primary drugs, and the doses are pretty maximized, right? So we can't move there. The American Heart Association, which is half of the guideline group, right? So when they publish an update a year after the guidelines are published, it's sort of the same group. So you view this as sort of an extension of the guideline I shared with you. They have a stepwise approach to managing resistant hypertension. The first up there, exclude other causes of why somebody may have high blood pressure or refractory high blood pressure. The second part of step 1 is lifestyle. And the third part is to optimize the doses in your 3-drug regimen. Already there, check mark and Rhonda, right? We're there. Step 2 Yeah, substitute a weaker thiazide with a stronger thiazide. So maybe use chlorthalidone ahead of hydrochlorothiazide. Did that with Rhonda, check. Maybe that's actually why. Maybe to control blood pressure, they switched from hydrochlorothiazide to chlorthalidone or started on chlorthalidone. I'm not sure exactly which, but there is some data that shows that when you switch to chlorthalidone, you get more blood pressure lowering. Milligram per milligram, it's a little bit stronger. So we're already at step 1 and step 2. How about step 3? Step 3 is add a middle receptor antagonist like spironolactone or eplerenone. Oh, okay. Specific aldosterone antagonist, because sometimes the underlying pathophysiologic abnormality that causes resistant hypertension is patients making too much aldosterone. So an aldosterone blocker like spironolactone would directly target that. But we have to be a little cautious in people with bad kidneys because of potassium elevations. I've seen some bad, has anybody seen bad potassium elevations from spironolactone? I have seen it to the point where I have to stop therapy. It does happen. I've seen it with some birth control pills that have a spironolactone-like product in them that raise potassium. So we have to check potassium in some of our patients, depending if they're on Yasmin, that older birth control pill that can raise your potassium because it's spironolactone-like. This woman's GFR is 35, so you still can use that. You just need to check that potassium. And actually, if I look back at her, I'm just going to go back a bit. I don't recall, do we have her potassium on? Oh, serum potassium is 4.4. So what do you think about adding spironolactone? It might raise it a bit, but if it was 5, I wouldn't do it. I would consider it with observation and monitoring just to make sure it doesn't go too high. Because the other options, step 4, 5, and 6 are a beta blocker, hydralazine, or using a drug like minoxidil. You do see that these last steps, 4, 5, and 6, are not evidence-based, where steps 1, 2, and 3 are evidence-based. So we have good information that spironolactone or eplerenone as aldosterone antagonist or mineralocorticoid receptor antagonist, those are the same thing, that they work for resistant hypertension pretty well to get people controlled. Something that we don't see up here is clonidine. Do you see clonidine used in practice? I see clonidine. Do you like it? What's that? For sure. Yeah, you know, it's a bugger because does it work? Yes, it works. Does it cause side effects? Yes, it does. It can cause anticholinergic side effects, but it lowers blood pressure, so we still see it used. There's the problem with clonidine is there is a rebound hypertension that occurs if you miss a dose. It happens with beta blockers too. I was surprised to see that in 2018, this is what the American Heart Association said. They called out appropriate use of arterial vasodilators. They even commented with the beta blockers that you can use an alpha blocker too, with some caution because of side effects. But for clonidine, when they talked about the alpha agonists, you know, there's issues with side effects. They had this statement, I quoted it, per the scientific statement. They say clonidine tablets should be avoided because of the need for frequent administration and the risk of rebound hypertension. They advocate if you're going to use clonidine, to use a transdermal patch for that purpose. Now, this is one where I don't think practice has caught up to this recommendation because I see a lot of oral clonidine. And clonidine is used for off-label neuropsychiatric indications to decrease craving in people who are going through addiction withdrawal. But it is something maybe to keep in mind that if you see some people being critical of oral clonidine, it's because of this. And heck, if somebody's on oral clonidine, I really educate them, don't miss a dose. Try not to, because if you're already on it, you're probably on multiple drugs already, and that rebound hypertension could just make things a little bit worse. So for Rhonda, remember she's 6 years into her, her first visit, and she still has uncontrolled resistant hypertension. She meets the criteria. 3 drugs, they're all the right drugs, they're all max dose, and she still is not at her blood pressure goal less than 130/80. She has the need for aggressive blood pressure lowering. Not only does she still have diabetes and CKD, but she also has a history of a stroke. Now, it was a year ago. Sometimes people immediately post-stroke, we don't want to lower their blood pressure too quickly, but a year out, do it. Yeah, a month out, I would do it. When somebody stabilizes, when you can actually confidently really lower their blood pressure to an appropriate goal. I would reinforce her lifestyle modifications, and I would do spironolactone. Some clinicians would start at 12.5 milligrams and monitor potassium. In our practice, I'd start at 25 because her potassium is 4.4. I expect it to go up. I hope it doesn't go above 5. I don't think it will, but it could. because of her kidney disease. So it would require monitoring in at least 4 weeks. Some people too would monitor potassium even sooner than that. They would bring her back within a week to remeasure it. Yes. Would I bump up the high gluten, which is chlorothalonone, before going to adding on spironolactone? It is an option. If so, I could accept that if I just monitored and brought her back. I would want to look at her uric acid again. It is an option. You start getting to what I call the flat part of the dose response curve. So a lot of times you get your most effect when you start the drug or go to the first dose up. Going from 25 to 50 of chlorothalonone can be done. I don't know if it'll give her a 10-point. She was at 138, and I probably need a 10-point reduction. So I would think that she probably would need a fourth drug added on. It is an option though, and I wouldn't. It's not wrong. Would you do that, or have you done that in some of your patients? Yeah. Her potassium can tolerate it. There are, interestingly enough, too, there was a recent New England Journal article that just came out, and I think it was November, that looked at chlorothalonone in CKD patients, where at one point, and you may hear this, it's a myth that people with bad kidneys can't use diuretics. Have you heard that? Can't use thiazides. They looked at people with GFRs less than 30, and chlorothalonone still worked. So it's longer acting and stronger. Now she's not less, she's 35, right? Her GFR was 35, so you still can use chlorothalonone. And so, I'm answering your question. You can go up to 50, and I would monitor and just see if it works. But if this woman, let's say her GFR, oops, there's a typo. Her GFR is 25. Some clinicians say, oh, I got to get rid of the thiazide. No, now there's data that actually chlorothalonone especially works well in people with advanced stage 4 CKD. So I didn't add any content with that, but that's true. Let's do one more patient case before we take an additional break. This is a secondary prevention patient. So it could be Rhonda, because Rhonda turned into a secondary prevention patient, right? Let's see what this person brings us. This is Salvatore. He's not that old. He's 53. Diagnosed 3 months ago with PAD, peripheral arterial disease. So atherosclerosis in those leg arteries after symptoms of intermittent claudication. So intermittent claudication is almost like angina. When you exert yourself, you start getting the cramping and the ischemic symptoms in the legs. They're reported in an ankle brachial index measurement, which is looking at the systolic pressure in your brachial index versus your ankle measurement versus your brachial measurement, and looking at that ratio. And it indicated that the ratio was less than 0.9, which means less perfusion down there than up here. It's diagnostic for PAD, especially with those symptoms. He actually had a revascularization procedure. It does happen. Even though he's 53, his symptoms must have been bad enough, or maybe he had severe leg ischemia or critical limb ischemia. He had a recent revascularization procedure, and it relieved his PAD symptoms. So it relieved his intermittent claudication. That's good. You probably have had some patients that have had severe PAD where they've had that revascularization. Now he's back. He's referred back to primary care after being cared for by his vascular surgeon. And we were consulted to further maximize his cardiovascular risk. This one was adapted based on something not too long ago. His medical history includes hypertension, high cholesterol, coronary disease. So he's already had, so this is somebody, we call them vasculopaths, right? Multiple forms of, you've seen them, right? Early in their life. He's had an MI, and now he has PAD, 2 forms of clinical ASCVD. It's probably because he's a smoker, and probably genetically he's got some predisposition to it. He also has hypothyroidism and PAD. So I'm already thinking this guy's got a lot going on. 2 forms of clinical atherosclerosis. He is in cardiac rehab, and he sees a dietitian, but he's still smoking a half pack per day. In reality, this person did cut back, but they were unable to fully quit smoking. Probably was a reason why he had PAD and coronary disease, because of the extensive smoking history. But he doesn't drink a whole bunch of alcohol, 1 to 2 drinks a month. So that's definitely moderate, or modest, I should say. Family history, he has a strong history of premature ASCVD in multiple primary relatives. So sort of not that surprising. When you see actually multiple forms of atherosclerosis in somebody only 53, you think, what's going on? Well, you couple that with a family history. You've seen these patients before, right? You're nodding your head in the back. I'm like, yeah, I can think of a lot of people that fit this kind of picture. What is this man on? He's on carvedilol, a beta blocker, a strong beta blocker, twice a day. Lisinopril, amlodipine, levothyroxine, rosuvastatin 40, so high intensity, and ezetimibe, and he's also on aspirin. His blood pressure is looking great. It's definitely less than 130/80, and he's on, basically 3 antihypertensives. So I'm happy. No diuretic, but he didn't need it right now. So that's good. He's on the beta blocker because of his post-MI history. His heart rate's 58 beats per minute. Some people may think that is low, but I think it's a marker. He's taking his carvedilol. His BMI is good. He's not overweight. He just smokes and has bad genes. What's that? Where do you want his heart rate? So if you're looking for people with ischemic heart disease, where they have angina episodes, the AHA guidelines recommend titrating to 55 to 60 as a marker of beta blockade. So I don't know if he's had ischemic symptoms, but that's for people with chronic stable angina. But if you extend that, that's a safe zone, I think. And carvedilol 25 BID is a pretty good dose. You can go up to 50 BID, but it's probably just because of that. Maybe I don't know if it's his physical activity. He's in cardiac rehab right now, but it's because he had a revascularization procedure. Here are his labs. So his comprehensive metabolic panel on the left, nothing's in red, but just to call out, his potassium is in the 4s. Let's see, his creatinine is normal. His GFR is normal. No high uric acid. Oh, so overall, good liver function test. His metabolic panel is clean overall. Lipid panel, ouch. Ooh, okay. This isn't good. Let's take a look at this. Before treatment, it was looking really bad. His total cholesterol was 330. That's before treatment, which was a while back. Remember, he's got the family history of heart disease. His LDL was 235. He has familial hypercholesterolemia. And it happens. People who's seen an LDL in the 200s? Yeah. A lot of people have. If you see a lot of lipid panels, you will find these patients. His LDL was 235, HDL 35. There's something called lipoprotein A, which is a lipid biomarker, and it was really elevated in this guy. LPA is not something you target therapy for, but it's another marker that patients may have atherogenic lipoproteins. It's sky high in him. I'd like it less than 30. His is almost 300. That's in our PAD clinic at the university, when we see these people with multiple forms of vascular disease, often their LPA is high. It's a genetic thing. It's hard to modify. There's drug in development to modify it, but at least it makes me want to be aggressive. And heck, people were aggressive with his drug regimen, high intensity statin and ezetimibe. But look how well it's, let's see, his LDL is down to 105. It's gone from 235 to 105. That's more than a 50% reduction. But is it good enough? No, it's still not good enough. So I'm glad that the LPA is still high too. So he still has risk. His thyroid's good. He's on levothyroxine, and his A1C shows he, wasn't even done today, but it was 5.8 3 months ago. So he's got some cholesterol issues here. I guess if we look at just PAD though, I want to focus in on the PAD end of things because there's been some recent innovation. There's older guidelines from 2016 about what to do in people with peripheral arterial disease. It is a standard of care. These class 1A recommendations in PAD, use an antiplatelet agent, use a statin, high intensity because it's considered secondary prevention, and treat them with antihypertensives if they have hypertension. Absolutely do it. Those are standard of care. Good to see them called out. Advising people to quit smoking, using smoking deterrent medications. Hey, maybe this person is eligible for Chantix, right? Or for something, nicotine replacement therapy, anything to get them to quit smoking. Strongly recommended, no surprise there. Here's where we're seeing some differences. In the bottom, we see cilostazol, which is a drug that only is indicated for intermittent claudication. Perhaps before his revascularization, that was an okay drug to use. Its only contraindication is really heart failure. He doesn't have that, but it's been relieved, so I don't think we have to go there. I want to focus on the oral anticoagulation. In 2016, usefulness was uncertain, and do not use it to reduce cardiovascular events. So if you look at these 2016 guidelines, you would say, oh, don't even think of an anticoagulant. But things change. Things change, and in 2020, there was a huge study called the Voyager study, which will change practice. And it actually was a double-blind trial in PAD patients who had revascularization surgeries. And they evaluated using low-dose aspirin alone versus low-dose aspirin with low-dose rivaroxaban. And people given both the low-dose rivaroxaban, which is a DOAC, along with aspirin, actually had better results. They had the efficacy that was measured was acute limb ischemia, cardiovascular death, stroke as one composite endpoint. And it was reduced. It went from almost 20% down to 17.3%. So there was a 15% risk reduction in that big endpoint. There was major bleeding trended to be worse. No surprise with the combo. It wasn't statistically significant, but it was trending up there. But this showed data of efficacy. There's a similar study looking at low dose, and this is 2.5 milligrams twice a day, which is lower than that full anticoagulant dose, right? But there's another study looking at people post-MI called the MATCH study, which showed that low dose rivaroxaban with aspirin was better than aspirin alone. So that was just in heart attack or vascular patients. This is setting a standard. Don't be surprised to see low dose rivaroxaban used with aspirin in certain clinical secondary prevention patients. But after a PAD revascularization, I think this is some of its stronger data. You will see this if you get patients that have had a revascularization in their peripheral arteries, you'll see them come to you on low dose rivaroxaban. So if you're a pharmacist provider, you may think, oh, more bleeding, but actually there's evidence to support that. It's not, but the guidelines have just lagged behind because they haven't been updated since 2016. This patient also has a history of an MI, right? So 2 forms of vascular disease. What do the guidelines say for just stable ischemic heart disease, which includes post-MI patients like Salvatore? So lipid management, yep, got that. That's recommended. Smoking cessation, of course. But therapy to prevent death, we still see antiplatelet drugs used quite readily and recommended. Low-dose aspirin as a class 1 recommendation. If you can't use aspirin, use clopidogrel. Beta blockers are recommended. He's on carvedilol, especially 3 years post-MI. That's where there's the best proof that a beta blocker post-MI not only controls blood pressure, but decreases stimulation of the heart so you don't have a second heart attack. There's reasons to continue it thereafter based on your patient. We see ACE inhibitors and influenza vaccination. Matter of fact, even COVID vaccination should be used in high-risk secondary prevention patients because and it's nothing miraculous about, using the vaccine. It's just avoiding a bad viral infection is important because viral infections in people with bad hearts can actually cause more health consequence. We've known that. There's nothing new in that. That's been just sort of goes under the radar, but it's still important. So our patient Salvatore, he's checking a lot of these boxes. He's on an antiplatelet, he's on a beta blocker, he's on an ACE inhibitor, which is recommended just for some of the benefits of maybe reversing some of the scar tissue in the heart that occurred from the heart attack. They call that remodeling benefits. It's been coupled with a decreased risk of heart disease. So he's pretty adherent or compliant with what's recommended for stable ischemic heart disease. But his big gap might be, in addition to rivaroxaban, might be lipid management. 235 is terrible. 105 is a lot better for an LDL, but still not good enough. And our lipid guidelines, in 2018, when I shared them with you, they were influenced. This is just a timeline of all our major cholesterol guidelines, and below on the bottom of the arrow are major clinical trials that influence them. The latest version in 2018 of our cholesterol guidelines were influenced by 4 big trials. One's the HOPE-3, that's a primary prevention population. But then PROVE-IT, FOURIER, and ODYSSEY were studies that looked at ezetimibe and then 2 of the PCSK9 inhibitors, specifically in secondary prevention patients. So that's why we see, and there's something called REDUCE-IT, which, this is a bugger. This used an omega-3 fatty acid and showed benefit. So let me share that with you because maybe there's something in these new cholesterol guidelines that would benefit our patient, Salvatore. So if we deal with the REDUCE-IT first, what is REDUCE-IT? It's a study that looked at prescription omega-3 fatty acids. And we know we were talking about fish oils, over-the-counter and prescription omega-3 fatty acids. I have a love-hate relationship with these medicines. So my hate relationship is mostly the over-the-counter fish oils because they're unregulated. Also because they smell like fish and they cause fish eruptions. You know what fish eruptions are? Fish burps. That's a side effect because when you get fish oil, it's crude fish oil, which means, for like it better or not, manufacturers crush the fish. They don't euthanize the fish. They crush them in a vat, right? And some people, oh, that's so cruel. I mean, what are you going to do with these little fish, right? There's usually small fish, like the sardines and all that. They crush them, they extract the oil. And if it's crude fish oil, they put it in a capsule. And usually 30% of that crude fish oil is good stuff. The good stuff is called EPA and DHA, eicosapentaenoic acid and docosahexaenoic docosahexaenoic acid, DHA, hard to say. Those are the two forms of omega-3s which lower triglycerides. The other 70% in the over-the-counter regular garden variety fish oil is crude fish oil, which smells like fish, has calories, but is not an omega-3. So that's what we get with over-the-counter fish oil. It's mixed with EPA and DHA, crude fish oil. The dose, who knows, because it's not approved by the FDA for anything. And take with food, I don't know. They say take it with food, but there's no like strict guidelines. For the two prescription products that we have available, there's omega-3 acid ethyl esters. That goes under the brand name of Lovesa, but it's also available as a generic. It includes EPA and DHA. So both two omega-3s. And you take it with food to promote absorption. 4 grams a day is the approved dose for very high triglycerides of 500 or greater. Then we have in the middle row a product called icosapent ethyl. This is there is a generic that's evolved too, but it's only it has only some of the indications of the brand name product. Icosapent ethyl is different. It's an omega-3, but it only includes EPA. It only includes icosapentaenoic acid, no docosahexaenoic acid. So no DHA, only EPA. Same dose, still need to take it with food. Both share the indication for very high triglycerides. So if you have somebody with triglycerides of 500 or higher or 1,000 or higher and you want to prevent pancreatitis, you can use either of those products. But there's something special about the icosapentaenoic acid. It is FDA labeled, only icosapent ethyl, which is EPA only. It's got an FDA indication to reduce cardiovascular events. And it's for people that don't have triglycerides of 500 or greater. It's for people with triglycerides of 150 to 499. You've probably seen the commercials for Vosipa, the brand name, icosapent ethyl. They have some data and they have the indication. It's from their Reduce It trial. So what's the deal here? This is a prospective double-blind trial over 8,000 people. And these were either secondary prevention patients or diabetes patients who were primary prevention. Mostly 70% were secondary prevention, about 30% primary prevention diabetes patients. All of them were on a statin. All of them were on enough statin to get their LDL between 41 and 100, which is probably good for the diabetics, but for the secondary prevention patients, I don't want them between 41 and 100. I want them actually less than 70 for the record. So that's like a little limitation. The average was about 75. So maybe it could have been optimized a little better. But nonetheless, these patients had to have one other inclusion criteria. Their triglycerides had to be 150 to 499. Now they had a plus or minus 10% cutoff, so it went down to 135 to 499. The FDA labeled indication is 150 to 499, just for the record there. So these people, they were high risk because of diabetes or heart disease, already on a statin, LDL mostly controlled. Half of them went on placebo, half of them went on icosapent ethyl. And the people that went on icosapent ethyl had a significant reduction in cardiovascular events. Pretty good. 25% relative risk reduction. But this study went 5 years. And if you look at the actual numbers, the incidence went from about 25% to about 20%. That's a big reduction. Going down a net cut, that's a number needed to treat of about 20. So pretty impressive. And I didn't believe it when I first saw it. I'm like, no, this can't really be true. There's got to be some backstory. The placebo was mineral oil. And people say, why would you use mineral oil? Has anybody seen Vosipa? It's clear. So they had to use, the FDA told me to use mineral oil. It was FDA recommended placebo to use mineral oil because it looked like the real capsule. Where all other fish oils, have you seen them? What color are they? They're yellow. So you can't, you would, if you used, I don't know, if you didn't use something clear, that you wouldn't be able to use a masked placebo. So that was FDA endorsed, but this is pretty overwhelming. If you go to these benefits, so hey, this is pretty compelling that our patient looks like their LDL is 105, so they don't quite look, I want a better controlled still. But what if his LDL was 90? He'd be able to be enrolled in this trial and he'd fit the FDA labeled indication for adding on icosapent ethyl. So what do some people say? Well, icosapent ethyl is expensive. It's brand name. Well, there's one evolving generic, but doesn't have the indication for risk lowering. Some people say, well, let's just use a cheap generic. Let's use the Lovesa generic, right? Well, Lovesa generic, omega-3 acid ethyl esters, Yes, it is an omega-3, but it's got both EPA and DHA in it, right? And if you look at EPA and DHA, there is no cardiovascular event lowering. This went under the radar to some extent, but this is a big outcomes trial called Strength. It looked at prescription EPA and DHA versus placebo. Same kind of study design, high-risk people, LDLs that were controlled, triglycerides, I think were 180 to 499 in this trial. Primary and secondary prevention patients, so very similar. And they randomized people to the mixed EPA and DHA, which was omega-3 carboxylic acids, a slightly different formulation than the generic Lovesa, versus corn oil. And they used corn oil because the native drug is yellow, so they had to use a yellow oil. Even some people, if they popped open the capsules, if it doesn't look like oil, they would know it's. So they really, this was their masked placebo. And they looked at cardiovascular events. And fortunately, unfortunately, they stopped this study early. After multiple years, there was no trend in cardiovascular events being different. It was about 12% versus 12.2%. So they stopped this study after, I think it was about 3 years because of futility. They weren't going to see a difference. So why am I sharing this with you? There are benefits with EPA only for cardiovascular events, but not with EPA and DHA. And that's the proof of it. The carboxylic acid, omega-3 acid drug that was used here, it was called Epanova. It was FDA approved in 2014, but the company never put it on the pharmacy shelves because it leaked out of the capsule, they say, and they were working on the formulation, but they were waiting for this study to be positive. And because it was not a positive study, they pulled. They're not going to market the drug anymore. But it's very similar, if not the same as Lovesa, because it contains EPA and DHA. So this makes it sort of hard. If you're looking at omega-3s for cardiovascular event lowering, it's only the EPA one as an add-on to a whole bunch of other stuff. But the FDA gave the indication, the ADA, the European Cardiology Society, and the National Lipid Association, they all say what the FDA says, that adding icosapent ethyl to a background of statin therapy in high-risk people that have well-controlled LDLs, but have this mildly high triglycerides, that you can use it as an add-on. It's an expensive add-on. It still requires prior authorizations in my neck of the woods in Colorado. It's hard to get it approved. We have gotten it approved in some patients. Even our state Medicaid covers it if the criteria are met, which is basically the Reduce It study, if people look like that, and the FDA label. But it's one that we're getting to the point where once a patient's eligible for this, there's a lot of other, they should be well controlled in a lot of other venues. But one thing that I guess I didn't expound enough on, maybe I did, is I think it's more important personally. I would pick LDL over maybe using a prescription omega-3 as maybe a more proven strategy. I like the Reduce It study with omega-3s, but it's one big study. Where look what we have with LDL. We have a multitude of different trials, and this is putting them all together in a meta-analysis, looking at basically how much event reduction you get based on how much LDL was reduced in a clinical trial. And we see a pretty predictable relationship. It's when you put them all together, there's some noise. These are all different trials, these different square boxes, and then the diamonds are basically all the trials together. But these are trials that looked at high intensity LDL lowering versus some step below that. And the message here was lower is better in high risk people. And that for every 38 milligrams per deciliter of LDL reduction, which is 1 millimole, you get about a 22% additional reduction in vascular events. So this is sort of that lower is better in high risk people from an LDL perspective. And if I think of Salvatore's LDL is 105. He's on a high intensity statin and ezetimibe. So ezetimibe is Zetia, the brand name. I didn't maybe make that clarification. It's a cholesterol absorption inhibitor. Remember, it lowers LDL about 18%. Those 13 to 20% is the range. The reason it's in guidelines, because remember that secondary prevention algorithm, it was basically, I said, doesn't matter if you're very high risk or not. After high intensity statin, the recommended next drug is ezetimibe. Part of that is it's cheap, right? It's generic. It's not very expensive. But there's one study called, it's not the best study in the world. It's called the Improve It trial, which was one of those 4 trials. And it was a huge mega study, 18,000 patients. All these patients were secondary prevention. They were all on a background of simvastatin, not the strongest statin, but this is an older study. And half of them went on placebo, half of them went on ezetimibe, and there was a reduction in cardiovascular events. It wasn't that big. It was a 6% relative risk reduction, but it was significant statistically. Not much bang for your buck because it doesn't lower LDL all that much. It made LDL go from 69 down to 53. So still, if you don't reduce LDL a lot, you don't get a lot of event lowering, right? But because it's affordable, it's recommended as maybe it'll get people to goal. That's the logic behind that. It was cost driven. It's a little bit different than the PCSK9 monoclonal antibodies. The PCSK9 monoclonal antibodies are alirocumab and evolocumab. So Praluent and Repatha are the two brand names here. The injectable every 2 to 4 weeks. They're fully human monoclonal antibodies. That's why they require prior authorization. Traditionally, they've been dispensed out of specialty pharmacies, but now you should be able to get them in regular pharmacies because they're becoming a little bit more mainstream. They're an adjunct to diet and exercise for people that need more LDL lowering if they're already on maximally tolerated statin therapy. The FDA label does not require them to be on ezetimibe. It just requires, it says maximally tolerated statin therapy. And hopefully that's high intensity statin therapy, but in some people, maybe 0 milligram statin, right? It may be that they can't tolerate any statin. It does have the FDA label, just might not be covered by your insurance if they're not on a statin. We see the two products down there. They're approved to reduce cardiovascular events and secondary prevention. And it's because we have studies. And I don't want to go over these in too much detail, but there's one called Fourier, one called Odyssey. The Fourier study, it sounds a lot like the ezetimibe trial, but it's a little different. Similarities is it was big, 27,000 people. That's like a little city, right? That's a lot of people, or a little town, I should say. Randomized double-blind trial. They looked at people with secondary prevention. They were on maximally tolerated statin therapy that still had LDLs that were 70 or higher. So sort of sounding like the guidelines, right? Secondary prevention. These actually were very high-risk people because they were soon after their acute coronary syndrome. So high risk, on statin therapy, but their LDL still remained 70 or higher. It was maximal statin therapy. In this particular study, about 70% were on high intensity statin and about 30% were on moderate intensity because that's their highest tolerated dose. Half went on placebo, half went on evolocumab, which is one of the PCSK9 monoclonals. And this study only went 2.2 years. It didn't have to go any further because there were significant differences. The curves are separating. After 2 years, they continue to separate. There's a further analysis to say they separate even more. So the study didn't have to go any further because they met their endpoint, a significant reduction in vascular events. The other, and I guess one thing I do want to highlight is this lower is better was seen in this Fourier trial. It's a little bit difficult to explain, but what they plotted here were on the y-axis, people that had a cardiovascular event as the primary endpoint. And on the x-axis on the bottom was their achieved LDL value. So you can see, and they're quartiles of patients. So they looked at people with the lowest quartile, the second quartile, third and fourth, as far as their LDL measurements. And the red is with drug therapy and blue is with placebo. But I think what I see here is a line that shows that people with the lowest LDL values had the lowest cardiovascular events. You can see that because it's going down, right? And there's a whole quartile here, getting back to that question about safety of lower LDL values. A whole quartile of patients had a median LDL of 20. So that's pretty low. And they looked at they did all the safety things, and they did extensions of safety analyses, and it looked clean. So at least harm was not there. So these are high-risk people, not just primary, they're not primary prevention. These are high-risk patients. So when I say lower is better, I'm framing it in people that need lower, which is a high-risk patient, a secondary prevention patient. The other study with alirocumab, same thing. Secondary prevention people on maximally tolerated statin, but their LDL remained at 70 or higher. They were randomized to alirocumab or placebo. Primary endpoint of cardiovascular events, 15% relative risk reduction, the same actual number. It went 2.8 years versus 2.2 years, but we're seeing it should be the same, right? Because it's similar population and the same amount of reduction in LDL of about 50 to 60%. So this is why these two studies are why in the guidelines, they say for secondary prevention, if you're very high risk, to add a PCSK9 monoclonal antibody. The only thing that's different, and I will call this out specifically, is the guidelines recommend being on ezetimibe first. only because of cost, not because of outcomes data, but at the point, and I think it's important to emphasize this, when those guidelines were written in 2018, these two PCSK9 monoclonal antibodies were much more expensive than they currently are. They were $1,100 a month. I think after they got wind that the guidelines were not going to recommend them before ezetimibe, they cut their price by 60%. They went from $1,100 a month down to $500. $500 is not cheap, right? It's more in line with what an SGLT2 inhibitor or a GLP-1 receptor antagonist is. Still expensive, but clearly $1,100 is way too much. Yes?
Is there any studies done just from the standpoint of cost, of taking people off their statins?
Oh, that's a great. So the question is, are there economic or cost effectiveness studies looking at people transition them off a statin into a PCSK9 monoclonal antibody? No, I've never seen that. Probably because it would be so hard to get rid of a statin just because the evidence is so strong unless you had a reason like side effects. Like if you had a population that were intolerant, I can see that, but otherwise they probably wouldn't get it approved by any research board because they'd view it as going against evidence-based medicine. But if there's reason, yeah, I've not seen that. That would be interesting. I think that I think the benefit is parallel to the LDL lowering. So if you swap out a statin that's lowering LDL by 50% with the monoclonal antibody that does the same amount, I would estimate that you get the same results. I think you'd have to have more reduction to get better results. There is bempedoic acid. Ooh, bempedoic acid is a newer drug. It's a citrate lyase inhibitor. It's novel. It's sort of hard to see on the projection, but that's the liver. This drug works in the liver, and it works by blocking the conversion of citrate to acetyl-CoA. And that's because this drug, bempedoic acid, gets activated in the liver through an enzyme that creates the active drug that blocks that conversion. Now, the reason you may have heard of acetyl-CoA is acetyl-CoA goes into HMG-CoA, which is the step where statins work, right? So it's the cholesterol production pathway is blocked with bempedoic acid, but very much in the early step, not later down here where statins work. It's more effective to block down here than it is up here, but this is an oral drug that was approved. And you know what? Our patient would be able to get it on label. It was approved in 2020 for patients with ASCVD or with familial hypercholesterolemia for further LDL lowering in addition to maximally tolerated statin therapy. This person that I shared with you is on, I think, rosuvastatin 40. That's the maximum dose. That's actually the strongest dose of the strongest statin, I guess, right? So on label, he'd be eligible for this drug. It's an oral pill, 180 milligrams once a day with or without food. It comes in a fixed dose combination with ezetimibe, two brand name products. It can increase your uric acid just like a thiazide can, about 0.8 milligrams per deciliter. And there's some other side effects that have, when this drug first got approved, it had a long list of side effects. And sometimes we see that and then they get better as time goes by, or sometimes they get worse as time goes by. So the uric acid is never going away. It can go up about 0.8 milligrams per deciliter. So that could be an issue. There's an interaction with simvastatin and pravastatin where you have to not use the maximum dose of those two drugs, but it's oral, so maybe it's good. I guess the rub is, though, it doesn't work all that well, right? So you can use it, but if you look at, there's these studies that got it approved, or the clear studies. Don't ask me why clear. Clear harmony and clear tranquility. So clear harmony is on the left, tranquility is on the right. On the left is like how you want to use a new drug on top of a statin. And on top of a statin, about 17% reduction in LDL. When you're comparing it to 50% with a PCSK9, I mean, that's like apples to oranges, right? A little apple and a big orange. If you use it in patients who are not on a statin, it does seem to work a little better. You can get up to about 24% reduction because the statin's already blocking the pathway to some extent. So if you block the top part of it, you're not going to get as much efficacy. So if you're not using any statin, so that's what you hear as this drug is marketed, you'll say, oh, statin intolerant patients use this drug. So yeah, it goes from 17 to 24% lowering. Still 24% is considered low intensity statin. And I say that to people and they get mad at me, but it's the truth. It's still low intensity. If you use it, and here's some of that data put together, I will mention if you're looking at no therapy versus bempedoic acid with ezetimibe, there's a fixed dose combo of that product, you can get 36% reduction. So if you team it up with ezetimibe, you can get close to what a moderate intensity statin. You can get the same kind of LDL lowering, which I guess is respectable, but still for a brand name copay for a new drug, I don't know if I wouldn't approve it and I wouldn't want to pay for it, even with with assistance. There is an outcomes trial. I guess, the world of lipid drugs, I've shared with you a whole bunch of drugs and they reduce cardiovascular events. Bempedoic acid, we don't know whether it lowers events. It's being studied. It's called the CLEAR Outcomes Study, another CLEAR study. This is sort of cool though. Sort of cool and sort of not cool. They're looking at people who are statin intolerant, who are secondary prevention. So that's good. It's a niche, right? People who are secondary prevention should be on a statin, but what if they're statin intolerant? Then they're looking at this versus placebo. So it's got some merit in that regard. The rub is their definition of statin intolerance doesn't mean that they're not on a statin. It means that they're on less than moderate intensity. So people could be on low intensity statin and be called statin intolerant and be in this trial. So it's a little play on things. It's people that can't tolerate moderate or high intensity statin, just for clarification. But that could be a lot of patients that we see. I certainly see them because they send them to me. Try to convince them to go on another statin. Now here's an exciting new one, inclisiran. I said it was in the previous slide said coming soon. Well, it has arrived. I just haven't seen it on the shelves yet because it got approved right before the end of the year. It's called inclisiran. Approved the same indication that we see for bempedoic acid. So either familial hypercholesterolemia or clinical ASCVD. So like Salvatore, like our patient, in addition to maximally tolerated statin. It's approved for LDL lowering. But this is sort of cool. When this drug was in development, I'm like, oh, how are we going to explain it? But now that we have mRNA vaccines, it's easier to explain. This is an siRNA drug. So it's small interfering RNA. Inclisiran, there's two parts of it. It basically gets, I don't want to say absorbed, it's administered subcutaneously, and it interferes with your mRNA in your body, which is mRNA mixed proteins, right? It's encoded to stop production of PCSK9. So in a way, we have drugs, monoclonal antibodies that get rid of PCSK9, and they allow our LDL to go down by having more clearance receptors for LDL in the liver. This drug sort of targets the same protein, just a different way. So instead of being a monoclonal antibody, it decreases your body's production of that protein. Sort of innovative and cool. It is subcutaneous. It's 284 milligrams. It's a 1.5 ml subcutaneous injection. That's a big one, right? So it's only approved for healthcare provider administration. Won't be self-administered. That's just the way it got indicated. They could have done 2.75 mLs, but they didn't. It's only, so maybe it'll get covered under your medical benefit versus your pharmacy benefit. So it has to be given in an office at month 0, 3, and then every 6 months thereafter. So a shot that lowers your cholesterol. And it lowers your cholesterol about 50%. That's pretty good because it's decreasing your body's production of the PCSK9. And so this is intriguing. It could actually, it's on top of statin therapy. There's no contraindications, no drug interactions. There's an approved label. The brand name is called Leqvio, Leqvio. So that's a different word, Leqvio, but or Leqvio. I think some people have called it that. It's going to be interesting to see how this drug is deployed because you can ensure adherence, right? You know whether a patient's getting their injection or not. Should be on top of statin therapy. If you look at the results in heterozygous FH patients, it lowers LDL about 45%, or about 40%, excuse me. But in patients with ASCVD, it looks like it's about a 50% reduction, especially when you look at the placebo-subtracted one. Depends. These Orion studies were the ones that got this drug approved. So 51.3% in one study, 45.8% in another study. So about 50%, which is respectable. It's what you would get with atorvastatin 80 in a lot of patients. There is an outcome study called the Orion 4 with this drug. So we don't know whether it lowers cardiovascular events, but we will. And sometime in the near future, you can look up in the website and see this studies are only 15,000 patients and they're secondary prevention patients. These patients will be also, for the most part, treated with statin therapy. So we'll see whether this offers an advantage. This study looks like the PCSK9 monoclonal antibody studies, similar kind of patient population. And I guess one of the last things, I think this might be the last one before we finalize the plan for our patient, is I did introduce LPA, and some people nodded their heads because in our patient Salvatore, his LPA was almost 300. LPA is an emerging risk marker. It's advocated by a lot of organizations for universal screening. So just like thyroid screen that we probably should universally screen and see if people have high LPA. If they do, it means they have a risk marker for the development of future cardiovascular events. It's very strongly recommended to be screened everybody 20 and up, but some people are trying to get it to be part of universal screening. There's papers on this. There's some issues with the measurements. Anything above 50 milligrams per deciliter is considered high, but most people would say being less than 30 is considered very normal. There's some labs that measure it in nanomoles instead of milligrams per deciliter, so you have to adjust the numbers based on that, which is a problem. The only medicine that lowers this LPA is a PCSK9 monoclonal antibody. There's one other drug in development. We don't know though if this is an example of a biomarker that just might be present in patients with high risk. I don't know if alone lowering it reduces or provides any clinical benefit, and we won't know probably for several years. But at least we know that patients that have high Lp(a), they have high risk for future development of events. So it may unmask people and identify those who may be eligible for therapy. So what do we do with Salvatore? So remember PAD, heart attack history, not good. He's on high intensity statin and ezetimibe. That LDL went from 235 down to 105. I mean, in addition to lifestyle and encouraging smoking cessation, what do you think about adding rivaroxaban load? If our goal is to further reduce his events, adding low-dose rivaroxaban would incur a higher risk of bleeding, but it's proven to reduce cardiovascular events. So it's a proven therapy. You will see your PAD patients after revascularization going on both rivaroxaban with aspirin. And if I'm asked to recommend what everything it can do to reduce cardiovascular risk, that's one of them. I also would add a PCSK9 inhibitor. I'd fill out the prior authorization myself. Somebody with multiple forms of vascular disease, that high LPA, and his LDL still is 105, even though he's had a 50% reduction, it's not less than 70. I would submit the prior authorization myself, and I would expect it to get approved if this person has insurance. I might reevaluate. I would put the icosapent on the back burner because I would 100% go after LDL first before I thought about adding another drug. And if his triglycerides were in that range and his LDL looked good, I might consider icosapent. I would probably get to the point where I'd think about cost burden, using a lot of expensive drugs and what the incremental benefit might be. That would be something I would consider, but I wouldn't have that conversation until later. And I would give him his influenza vaccination. If he didn't have his COVID vaccination, I'd push that one too. I think we can take another break. You guys ready for a break? Yep, let's take about a little more than a 10-minute break. At 20 minutes after the hour, let's reconvene. We got 3 more cases. They go a little bit quicker, so I will definitely have you out before 1 o'clock. I won't push it to beyond. I won't go beyond. All right, we're going to start back up. We have 3 more cases, and let's see if we might be able to get through all 3 without a break and get done before 1. What do you think? That a good target? All right. Let's talk about this primary prevention patient. See what's up with this one. Maybe a little different. This is Barbara. Barbara's a 50-year-old Black woman.